Paracentral acute middle maculopathy, or otherwise known as Pamm, was first described about 2013. This is a clinical finding and not a diagnosis, such as cottonwool spots are a finding, but it does not give you the diagnosis. The difference is the paracentral acute middle maculopathy is deeper in the retina, a little bit more difficult to see or almost impossible to see. But there are similarities in that many of the same diagnoses can give either cottonwool spots and or Pamm lesions. So again, it was first described not too many years ago, and it is a clinical finding. It is not a diagnosis. And what it is ischemia of the intermediate and deep capillary plexus in the retina. It can be associated with diabetes, hypertension, sickle cell, Purkinje retinopathy, and other vasculitides. It can occur alone or in combination with cottonwool spots and other retinal vascular findings. While some Pamm lesions are very easily seen and they are a deep retinal whitening, other times they can be very difficult or almost impossible to see clinically. And I'll show you an example of a patient such as this. Sometimes the only way you see it is with some hyperreflectivity at the level of the internal nuclear layer on the OCT, or sometimes you can see it on the infrared photography. Here is a patient with an inferior branch artery occlusion secondary to an embolus. The yellow arrow points to the embolus just on the edge of the nerve. The white arrow points to a small cottonwool spot, and then the blue arrow points to the areas of the Pamm lesion. And these are deeper areas of swelling of the retina. And here's the mid-face photograph of this particular patient. You can see there's a large cup disc ratio. The arteries are filled except for the inferotemporal arteriole. You can see that it is filled proximally, but as it comes to the area where it crosses the infratemporal vein, you now do not have filling of the peripheral arteriole. The superior veins are filled, the supranasal has a laminar flow, but the inferior vein does not yet fill with the fluorescein because of the infratemporal artery occlusion. Here is an infrared photograph of that same patient. You can see the dark areas corresponding to the areas of the interretinal edema or the Pamm lesions, and a couple of areas that are even darker yet, corresponding with the cottonwool spot pointed out near the arcade. And here's the OCT of that particular patient. The right side is the superior macula, and you can see all of the different levels of the macula, and they're normal. The inferior portion of the macula is on the left side of the cross section, and you can see the hyperreflectivity at the level of the inner nuclear layer, and there's some very, very faint shadowing of the outer nuclear layer and the interdigitation layer of the OCT. And here's an OCT of the patient 4 months later. The top cross section is the superior macula, and you can see the outer nuclear layer and the inner nuclear layer quite easily. On the lower OCT, it is in the area of the occlusion that he had. Right at the far right-hand side, there's still some ganglion cell layer that's intact, and the retina is thicker, but as you go farther into the flow of the infratemporal arteriole, you can see that the outer nuclear layer is intact, but the inner nuclear layer is no longer present, and the retina is thinner. So the prior slide was showing the superior macula versus the inferior macula after 4 months, and this slide here shows the acute phase and the 4-month later phase. On the acute phase, you can see very dramatically the hyperreflectivity of the internuclear layer. And on the lower photograph, you can see that now this internuclear layer has gone. This is a case of a 66-year-old gentleman who came to the emergency department pretty much for symptoms of a posterior vitreous detachment. When he came to the clinic, he said, I've also had this little blotchy film in the lower field of vision just below fixation, and this has been going on for the past week. And vision is good at 20/20, mild cataract, and we'll see what his testing shows in the slides coming up. So here are the infrared photographs. Right eye shows the epiretinal membrane, and if you look very closely on the left eye, there are some small dark areas just above the fovea. Here is the OCT of this gentleman's right eye. You can see very clearly that there is a posterior vitreous detachment and an epiretinal membrane, but otherwise it looks fairly good. But here is the OCT of his left eye. And if you look closely, there's just a slight area of hyperreflectivity just off the fovea. So he comes back a month later. He says the vision is mildly improved. He still sees the spots just off of fixation, but he notices them mainly while he's reading. So they're there, but they're small. So here's a comparison of what this gentleman looked like acutely and 1 month later. You can see the slight hyperreflectivity just nasal to the fixation, and then on the inferior OCT, you can see that there's thinning of the nuclear layer just at the nasal border of the fovea, and this corresponds to the small scotoma that he noted while he was reading. Now here's an example of a gentleman who had a fair amount of symptoms. He was 51 years old, and 4 months before he lost some vision in the right eye for about 5 minutes. He had a second episode about 4 days prior to his emergency department visit, and then 9 hours before the visit. His vision is at 2400, left eye is 20/20. So you have to be very careful about possible giant cell arteritis in this patient or some embolic phenomenon. But let's look and see what he looks like clinically. Now, as I mentioned, that there is a chance for embolic phenomenon and also giant cell arteritis, so that work was done with the CTA of the head and neck. That was negative. The C-reactive protein was elevated, but the sedimentation rate was well within the normal limits, and his triglycerides were a bit high. So here's a color photograph of this gentleman. The nerve may be a little bit pale, but the margins are sharp. There are really no emboli that we could see clinically, and I certainly don't see them on this photograph. The fovea may be just a little bit reddish. There may be a little bit of a cherry red spot, but to call any kind of retinal edema on the color photograph would be a far reach at this point. And here is this gentleman's testing. The upper right is the early phase of the angiogram. There's a little bit of patchy feeling of the choroid, but this pattern is not significant, and it is not a pattern that you'd see with giant cell arteritis. By the early venous phase, you can see that the patchy feeling is gone. The late phase shows some very, very faint areas of hyperfluorescence. The OCT gives the answer, and you can see the hyperreflective band in the layer of the inner nuclear layer. So in summary, paracentral acute middle maculopathy is a clinical entity similar to cotton wool spots, but instead of the swelling at the layer of the nerve fiber layer or the ganglion cell layer, The swelling here is at the inner nuclear layer, secondary to the superficial capillary plexus. The lesions can be cream colored or they can be almost impossible to see, and they are best seen sometimes with the infrared or the OCT. As with cottonwool spots, if you do find someone with a Pamm lesion, you do need to look for sources of vasculopathy and other sources for vascular occlusions.